Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent education grant from Ardelyx.
Welcome, everybody, to Breaking the Over-the-Counter Cycle, Optimizing Prescription Therapy for Patients with IBS and Constipation in Everyday Practice. My name's William Che. I'm the H. Marvin Pollard Professor of Gastroenterology and Professor of Nutrition Sciences at the University of Michigan in Ann Arbor, Michigan. And in this program, we'll discuss the following: the pathophysiology of irritable bowel syndrome, mechanisms of action of prescription IBS-C medications, the clinical data in support of those medications, and advancing from over-the-counter medications to prescription agents. Starting off with the pathophysiology, IBS is said to be a disorder of gut-brain interaction, and as the name implies, it means that there are peripheral factors that arise in the GI tract that interact with central factors that involve the autonomic nervous system and central nervous system in the brain. As the pictogram on the right side of your slide shows you, IBS is not a disease with a single pathophysiology. Rather, there have been multiple factors implicated in the pathogenesis of IBS. And it's probably useful to think about IBS as a number of different diseases that present with the same symptomatology. So, whether you're talking about things like GI infections, the role of food, altered intestinal permeability, the microbiome, uh, low grade inflammation, abnormalities of motility, psychosocial factors, or visceral hypersensitivity, these things interact to varying degrees in individual patients to lead to that clinical phenotype that we refer to as IBS. This slide sort of makes that same point, and it points out some of the real foundational pillars of the pathophysiology of IBS on that right side of the slide. Many IBS patients have motility abnormalities, visceral hypersensitivity, so they're hardwired in a way that makes them more sensitive to various types of stimuli in and outside of the GI tract. Altered mucosal immune function, so low grade inflammation, altered gut microbiota, or so dysbiosis, and then alterations in CNS processing. So the signals that are interpreted in the brain are overinterpreted so that patients are feeling pain and bloating. Patients with IBS suffer with a wide range of symptoms, as depicted on this slide. By definition, the most common symptom in patients with IBS is abdominal pain. You can see it's closely followed by straining, abdominal discomfort, and bloating. And after that, a wide range of symptoms that are reported less commonly, but reported nonetheless. Another important point about IBS is that it oftentimes does not exist in a vacuum. In other words, patients with IBS are much more likely to be experiencing other disorders of gut brain interaction, whether that be things like functional heartburn, functional dyspepsia, anorectal symptoms. And it also turns out, as you can see on the right side of the slide, that the more of these conditions that are present, the more severe the symptom burden is and the worse the quality of life is. So, focusing in on IBS. Well, IBS is a condition that's defined by the presence of recurrent bouts of abdominal pain in association with altered bowel habits. And in this case, we're focusing on constipation, so hard or lumpy stools. The criteria should be it should be present, it should be occurring within the last 3 months and should have had onset at least 6 months prior to your evaluation. Busy slide that transitions us from pathophysiology to treatment. I'm not going to go over all the details here. This slide would be worth taking a few moments and looking at on your own. It gives you an idea about what the American Gastroenterological Association and American College of Gastroenterology recommend as evidence based medical and non medical treatments for patients with IBS-C. Starting off with dietary and lifestyle approaches for patients with constipation. First, I think all of us are aware of the potential benefits of dietary fiber as well as fiber supplementation. And in general, the evidence is most supportive of a benefit with soluble forms of fiber, like ispragula husk or psyllium. Also, natural laxatives are increasingly part of the conversation when you're talking about treating a patient with either chronic constipation or IBS-C. So, realize that a number of fruits contain sorbitol, a sugar alcohol which is poorly or non-absorbed in the small intestine and highly fermentable in the colon. So things like prunes, apples, apricots, cherries, peaches, and pears, all the summer fruits in Michigan, by the way, are all contain relatively large amounts of sorbitol, which can exert a laxative effect. There are also foods that contain stimulant laxatives. So anthraquinones are contained by aloe, by cascara, and by rhubarb. Also, there are a number of other fruits which can also exert a laxative effect. Kiwi fruit is probably the most evidence based and one of the most interesting. Kiwi contains a protein called actinidin, an enzyme that seems to possess prokinetic properties in the human GI tract. And then things like ripe bananas, mango, papaya, and watermelon contain large amounts of fructose. And finally, FODMAP restriction can offer benefits to pain and bloating, not so much constipation, but pain and bloating in patients with IBS-C. As far as an overview of over the counter treatments for patients with IBS-C, again, psyllium is probably the most evidence based form of fiber supplementation. This is a soluble gel forming fiber supplement shown to have benefits not only for constipation, but for overall IBS-C symptoms. Osmotic laxatives include things like magnesium oxide as well as polyethylene glycol. And these agents have been shown to be a benefit for stool frequency and stool form, but not abdominal symptoms like pain and bloating in patients with IBS-C. Stimulant laxatives, again, excellent at stimulating laxation. So things like senna, as well as bisacodyl, stimulate bowel movements, but unfortunately are complicated by not infrequent complaints of abdominal cramping. Somewhere between 20 and 40% of patients utilizing stimulant laxatives will report some degree of cramping or abdominal pain. So, when should therapy be advanced from dietary lifestyle measures and OTC medications? Well, it's reasonable to try different OTC agents. And if you do that, make sure that you give an adequate trial. So, most people would say that somewhere between 2 to 4 weeks for each of the agents that you try. If and you should ask the patients what have you tried previously? Obviously, if a person has already tried polyethylene glycol for an adequate period of time, it's probably not worthwhile to try it again, or it would be lower on your list of things to try again. And you should consider moving to prescription medications if a person has tried one or more over the counter laxative remedies for at an adequate dose for an adequate period of time. This is the latest American Gastroenterological Association algorithm for the management of refractory constipation. And again, it emphasizes that starting with over the counter remedies and trying one or more of those is a reasonable thing to do before considering a trial with a prescription medication, either a secretagogue or a retainagogue. We'll talk about those in a minute. And if a patient has more constipation and little to no abdominal pain, so really just chronic idiopathic constipation, you could think about either a prokinetic, and if in other countries of the world, they also have an ileal bile acid transport inhibitor called elobixabat. We don't have that in the United States. As far as mechanism of action of secretagogues and retainagogues, for secretagogues first, realize that lubiprostone, which was the first secretagogue to be FDA approved, acts directly at the CLC2 channel, a chloride channel that leads to net secretion of chloride ions into the bowel lumen. Linaclotide and plecanatide are GCC agonists, guanylate cyclase C agonists. They actually lead to an increased production of intracellular cyclic GMP, which then opens CFTR, the cystic fibrosis transmembrane regulator, which is arguably the most robust chloride channel on the apical surface of the enterocyte. Remember that the negatively charged chloride entering into the bowel lumen will lead to passive movement of positively charged sodium as well as water. And you can imagine how that might be a benefit to patients that are suffering with constipation. Also, in the discussion are the retainagogues. So rather than leading to net secretion of ions like chloride, retainagogues actually inhibit reabsorption of ions like sodium in this case. So tenapanor is an NHE3 inhibitor, which inhibits sodium reabsorption. And again, that positively charged sodium in the bowel lumen leads to passive movement of electrolytes and water into the bowel lumen, which can benefit constipation. Now, linaclotide, in addition to helping with constipation related complaints, also has effects on visceral afferent pain fibers, actually reduces firing of visceral afferent pain fibers. And for that reason, this has been shown to exert benefits for visceral sensation, for abdominal pain and bloating. Tenapanor, again, acts at that NHE3 channel and inhibits sodium reuptake, and also seems to have benefits for intestinal permeability, which may lead to reduced activation of TRPV1 pain receptors and might provide an explanation for why tenapanor has been shown to be beneficial for abdominal symptoms like pain and bloating. So, when thinking about the potential or the benefits of over the counter medications versus prescription medications, realize that of the over the counter medications for patients with IBS-C, things like osmotic laxatives, stimulant laxatives, fiber supplements, and stool softeners, they all may offer benefits for constipation related complaints like stool frequency and stool form. But with the exception of soluble fiber, the others have not been found to be beneficial for abdominal symptoms like pain and bloating. On the other hand, the prescription medications, including the secretagogues and retainagogues, have been shown to be beneficial both for bowel related symptoms like stool frequency and stool consistency, as well as abdominal symptoms like pain and bloating. Of the FDA approved treatments for IBS-C that improve both abdominal and bowel symptoms, for the secretagogues, this includes lubiprostone, FDA approved in 2006, linaclotide, FDA approved in 2012, and plecanatide, FDA approved in 2017. And most recently, the retainagogue, tenapanor, was FDA approved in 2019 and eventually launched in the United States in 2022. Here's some data, the data from the phase 3 studies. We published the data for lubiprostone quite a few years ago now at this point, back in 2009. And you can see that there were small but statistically significant benefits in terms of improving abdominal pain and stool frequency in patients with IBS-C with lubiprostone, 8 micrograms taken twice daily with food. For linaclotide, you can see data from two large phase three randomized controlled trials evaluating 290 micrograms of linaclotide versus placebo in patients with IBS-C, and again, showing statistically significant benefits, in this case, a little bit larger than lubiprostone, with the number needed to treat ranging from 5 to 8. And then finally, plecanatide, the most recently FDA approved secretagogue, which was at a dose of 3 milligrams once daily, was shown to be statistically significantly superior in terms of improving abdominal pain and stool frequency in patients with IBS-C, with the number needed to treat of roughly 10. This slide shows you a nice analysis of the benefits of linaclotide for abdominal symptoms, including bloating, discomfort, and pain. And what you can see is early separation between the individuals receiving linaclotide versus placebo. For all three of those endpoints. In fact, you could see statistically significant benefits between weeks 1 and 2 of treatment. What's also interesting, though, if you look at these curves, is that the maximum benefit associated with abdominal symptoms was not achieved until weeks 6 to 8. While you do see some benefit almost immediately, maximum benefit can take a number of weeks before you actually see it. Similar data on or for plecanatide, again showing statistically significant benefits for bloating, abdominal pain, as well as stool frequency in patients with IBS-C. And here's the data for tenapanor. This is data from two large phase three trials that we published in the American Journal of Gastroenterology several years ago now, showing statistically significant benefits for the improvement of abdominal pain and stool frequency in patients with IBS-C with tenapanor at a dosage of 50 milligrams taken twice daily. Um, a- a- and, and, and a follow-on analysis from those phase three trials looking at the impact of tenapanor for abdominal symptoms, including abdominal pain, discomfort, and bloating. And again, showing early separation from placebo with tenapanor 50 milligrams taken twice daily compared to placebo. But again, maximum benefit not being achieved until somewhere in that 6 week range. It's also worth noting that tenapanor is beneficial, offers statistically significantly greater benefit to individuals who did not respond to a secretagogue. So the reality is that oftentimes you're thinking about using a drug after other things have not worked, and that this is data to support that practice, that patients who have not responded to a secretagogue can still respond to a retainagogue. In this recent network meta-analysis of different FDA-approved medications for patients with IBS-C, you can see that linaclotide, tenapanor, lubiprostone, and plecanatide all offered statistically significant benefits for overall IBS-C symptoms compared to placebo, and that there was no statistically significant difference in the likelihood of benefit between the individual medications. The same could be said for bloating. Again, linaclotide, lubiprostone, tigacerod, and tenapanor all offered benefits for bloating in patients with IBS-C, and there was no statistically significant difference in the benefit offered by those different agents. In terms of safety, the most common uh, side effects associated with all these drugs, so the secretagogues and the retainagogues, are GI side effects, and in particular, diarrhea. Linaclotide has been associated with diarrhea in around 1 in 7, so 15 to 18% of patients treated. Lubiprostone actually has a adverse event profile that's very similar to placebo. You can see around 13% of patients taking lubiprostone reported an adverse event versus 12% with placebo. Of the AEs, the most common ones were GI related AEs. And of the GI related AEs with lubiprostone, the most common one is actually nausea rather than diarrhea. For plecanatide, you can see again, mostly GI-AEs, slightly lower adverse event rates, at least as it pertains to diarrhea. And then tenapanor has diarrhea rates that are very similar to linaclotide. So, what do you do when you've tried OTC medications, prescription medications, and the patient's symptoms continue? Well, if a patient has persistent abdominal pain, you might think about neuromodulation. And we'll talk about some possible options with that in a second. You can also think about behavioral therapies, things like cognitive behavioral therapy or hypnosis. If a patient has persistent constipation, first and foremost, if you haven't already done it, you should think about the possibility of an evacuation disorder, the most common of which would be dysenergic defecation, that inability to relax the muscles around the lower part of the rectum and the pelvic floor and the anal sphincter to allow evacuation of stool from the rectum. And then finally, electroacupuncture. There's now compelling data from several randomized controlled trials suggesting that electroacupuncture can be highly beneficial for patients with IBS-C and chronic constipation. And then finally, for severely affected patients, these patients oftentimes require an integrated multidisciplinary approach. So, input from not only the gastroenterologist, but also urogynecologists, sometimes colorectal surgeons if it's really severe, and a multidisciplinary team of dietitians, behavioral therapists, physical therapists, along with the MDs. So, in terms of neuromodulation, you can think about tricyclic antidepressants. These drugs are probably the best for abdominal pain, and because of their anticholinergic and antihistaminic effects, they also have an antidiarrheal effect. So, in patients with constipation, you have to be careful with these drugs. SSRIs are very good for anxiety. And if you have a patient with a lot of comorbid anxiety, an SSRI might be a very reasonable choice. SNRIs are also good for abdominal pain. And then finally, tetracyclics like mirtazapine and trazodone can be beneficial, particularly for upper GI symptoms, but are prone to cause weight gain. So, a side effect to be aware of and careful about. In terms of psychological therapies, psychosocial therapies that have shown to be effective for patients with IBS. And by the way, this is not just IBS-C, but IBS-D and IBS-M, include cognitive behavioral therapy, um, gut-directed hypnotherapy, multi-component psychological therapy, and dynamic psychotherapy. There's evidence for all of those forms of behavioral therapy. All, unfortunately, the use of these behavioral strategies is oftentimes limited in clinical practice because of a shortage of GI psychologists and um, classically trained gastroenterologists are just simply not adequately trained to provide these kinds of services. Another way to do this is to utilize some of the mobile apps that can deliver behavioral therapies remotely. So that's something else to think about. So to conclude, IBS-C is a condition defined by recurrent problems with abdominal pain and constipation. The pathophysiology is heterogeneous but involves both peripheral and central factors. Management begins with dietary and lifestyle modifications along with over the counter medications. And when symptoms persist, prescription options, including secretagogues and retainagogues, can offer benefits to not only the bowel symptoms, but also the abdominal symptoms. So, pain and bloating. So, with that, I'm happy to entertain some questions. So let's see. I've got here, is there an optimal sequence for um, therapies, or do you just attempt treatments empirically? No, I think, it's most guidelines recommend starting uh, patients with chronic daily symptoms on an osmotic laxative. You can certainly try fiber first. In fact, the first line therapy in almost every guideline is a trial of soluble dietary fiber supplementation. If that doesn't work, either layering on or replacing with an osmotic laxative. So those would include things like polyethylene glycol or magnesium oxide. For occasional constipation, using a stimulant is a very reasonable way to go. So senna or bisacodyl. If those things don't work, then moving to a prescription laxative medication is a very reasonable way to go. And again, there's not head-to-head data between secretagogues and retainagogues, which are the ones that are FDA approved for IBS-C. So a lot of it is dictated, frankly, by what's covered by a patient's insurance. Remember that linaclotide offers dosing flexibility. There's three different doses: a 72 microgram, 145 microgram, and 290 microgram dose. Um, Plecanatide and tenapanor just come in one dose, one dosing schedule. All right, next question. Why not just use polyethylene glycol? You can. I mean, you can certainly start with polyethylene glycol. It's a very reasonable choice. The problem with polyethylene glycol is what I discussed during the presentation today, and that is that while there's very good evidence to support the benefits of polyethylene glycol for bowel symptoms like stool frequency and stool consistency, there's not very good evidence to support the benefits of polyethylene glycol for abdominal symptoms like pain and bloating. Again, the evidence resides for the secretagogues or retainagogues in that regard. So lubiprostone, linaclotide, plecanatide, and tenapidor. Um, do you ever combine over-the-counter and prescription medications, and if so, how? Yeah, all the time. For me, as a tertiary quaternary care specialist, it's not uncommon for me to have to combine medications. And typically, what I try to do is use medications with different mechanisms of action to try to make the um, multi-drug recipe complementary. So, for example, I'll use an osmotic laxative with a stimulant laxative. Um, I'll use a secretagogue with a stimulant. And I oftentimes will do that. I think there's also a lot of concern about using stimulant laxatives in patients with chronic constipation. And in particular, people are very concerned about the possibility of cathartic colon. So, with chronic use of stimulants, it leads to um, damage to the enteric nervous system that can actually exacerbate problems with constipation. Turns out there's no evidence that actually happens. Um, the evidence that is available suggests that um, some patients with on chronic stimulant laxative therapy have evidence of damage to the enteric nervous system, but it's not clear in those studies what's the chicken and what's the egg. In other words, is it that the stimulants cause the damage to the ENS, or was it that the ENS caused the constipation, which necessitated the stimulant? And we really don't know. There aren't any longitudinal studies to really help us to know, uh, to really establish a causal relationship between the use of stimulants and a progressive damage to the enteric nervous system. I think a good rule of thumb is this. Um, Try to use stimulants as a rescue medication or a medication for occasional constipation. But in the worst case scenario where a patient has really severe constipation, I think all of us that do this for a living have patients that are on chronic stimulant laxative therapy. So it's not a first choice as a daily treatment, but it can be very helpful for some patients with severe refractory constipation. So, so one question here is we all ask one: what's the rate of success with low FODMAP for IBS-C? Well, here's the thing: low FODMAP doesn't help with constipation. But what low FODMAP does help with is with abdominal pain and bloating. And in fact, if you look at all the trials, regardless whether they're done in IBS-D, IBS-C, IBS-M, the most consistent and robust benefits of the low FODMAP diet are on pain and bloating, not on bowel habits. You're more likely to get benefits for diarrhea than for constipation, but the benefits for diarrhea or constipation are not as consistent and robust as the benefits for pain and bloating. So, with that, I'm going to stop and thank you for your attention and for attending today. And good luck in treating your patients with IBS-C.